morning everybody. I am Dr. Niti Joshi, Professor Neurology with teaching experience of 25 years working as consultant neurosurgeon in Panvel. Today we will discuss the topic PCCL, that is percutaneous cystolithotomy or percutaneous cystolithotripsy. Indications for PCCL are bladder calculus which cannot be managed through transurethral route. This happens when there is too large bladder calculus and or too hard bladder calculus. Second indication, in elderly male patient when there is presence of prominent protuberant median lobe, or when male elderly patient is having significant endovascular tissue, that is the lateral lobes or the median lobe, where negotiation of the cystoscope sheath required for cystolithotripsy is not possible, or it will result into injury to the median lobe or endovascular lateral lobes, or in patient with tight non-passable urethral stricture, or where there is bladder neck closure, or in presence of very narrow rigid urethra. Also in case of pediatric age group due to presence of small size urethra, because instrumentation in narrow calibered urethra will result into significant injury with post-operative stricture later date. Bladder stones in pediatric age group in developing countries is due to endemic malnutrition. Due to malnutrition, the diet in these children is deficient in animal proteins and phosphorus. Also, there may be deficiency of vitamin A. In developing countries, bladder stone in the pediatric age group is composed of ammonium urate, while the bladder stone of the pediatric age group in the developed or the western countries is of steroid composition or steroid type. This is because etiology of bladder stone in pediatric age group of western or developed countries is spinal cord injury and or congenital abnormalities like spina bifida. So they have got neurogenic bladder, and such patients might have undergone various bladder surgeries or maybe reconstructive surgeries like augmentation cystoplasty. Because of this, such patients, pediatric age group patients, develop the bladder stones recurrently throughout their life, and so PCCL, which is less invasive as compared to the formal suprapubic cystolithotomy, is the treatment of choice. In this patient, because of neurogenic component or even because of augmentation cystoplasty, there may be incomplete emptying of urine resulting into urinostasis, stagnation, bacterial colonization, or urinary tract infection with urea splitting organisms. Also, there may be, because of augmentation, there may be mucus plug or even foreign body, all contribute to the formation of bladder stone which is of steroid type. We will discuss the procedure for percutaneous cystolithotomy or the percutaneous cystolithotomy in adult male with normal calibered urethra but presence of hard stone or too big stone. However, when the access through urethra is not possible due to tight non-passable stricture, or in case of pediatric age group when it is a narrow calibered urethra, then PCCL is performed under Siam guidance with or without installation of contrast medium in full bladder. Anesthesia for the adult patient where there is a too large or too hard stone is spinal anesthesia. Position, normal lithotomy position like cystoscopy with slight head-low position so that intestines will fall away from the operation site, thereby preventing injury to intestine during insertion of the Alkem's cannula as well as Amplas dilator. In first step in adult male patient, panendoscopy is done with smallest possible sheath like 17 French with 30 degree with adequate lubrication with good illumination and good irrigation flow. This is done for evaluation of urethra, prostate, bladder neck as well as bladder. Evaluation of urethra, prostate and bladder neck is to find out whether there is bladder outlet obstruction which is the cause of the bladder stone. While the bladder is evaluated for changes of bladder outlet obstruction in terms of trabeculations, cellules, saccules, diverticuli, or if there is any evidence of bladder stone, and stone for the size, number, whether the stone is in diverticulum, in any evidence of the trigonitis or cystitis because of friction of the stone with the bladder wall or trigone, and bladder capacity. Most important prerequisite for PCCL is that one has to make bladder full. This is because suprapubic puncture of the bladder and creation of percutaneous tract into bladder should be extraperitoneal. Due to bladder which is full, the peritoneum will get reflected from dome or fundus of the bladder and thus approaches extraperitoneal. Irrigation fluid used for cystoscopy as well as for PCCL is the normal saline and if possible warm normal saline so as to prevent hypothermia. Through cystoscope sheath, after completion of the pan endoscopy, irrigation with normal saline is continued to make the bladder full. One can confirm that bladder is full by inserting long 18-gauge spinal needle at the site of incision in midline. After this, the step of taking incision. The incision is about 1 cm long in suprapubic region, about 1 to 2 finger breadth, that is 2 to 2.5 cm above symphysis pubis, just like once take the incision for the suprapubic puncture by trocar and cannula. Incision actually, which is about 1 cm long, is taken with 20 number blade or 11 number blade in such a way that in case of failure of procedure of percutaneous cystolithotripsy, the same incision which is small can be extended on either side so as to convert it into proper financial incision so that immediately one can go ahead with proper formal suprapubic cystolithotomy without any delay. Length of incision in suprapubic region should be such that 30 French amplathe sheath can be inserted through it easily. After skin incision, incision is deepened through subacute and anterior rectus sheath and rectus abdominis muscle. Through this incision, 3-piece initial puncture needle, which is used for PCNL, is passed only for 4 to 5 cm in the direction of curvature of pubis. The initial puncture needle is passed under vision. This is very important that all the steps of PCCL are performed under vision. And in order to perform all the steps under vision, most important thing is that assistant is directing the tip of the cystoscope sheath, that is inner end of vesical sheath, towards the anterior abdominal wall, that is towards the anterior bladder wall. So whenever the initial puncture needle is passed, that time also when the initial puncture needle is passed, one can see that because the tip of the cystoscope is directed towards the anterior wall of the bladder on camera, one can see that the initial puncture needle is entering into the bladder. In order to confirm that initial puncture needle has entered into the bladder, after that we can remove the stellate and see the free efflux. Once the free efflux from the initial puncture needle is seen, then the 0.035 inch or 0.038 inch glide wire is passed through initial puncture needle in the bladder. This particular thing is also again observed under vision on camera with the help of cystoscope. After the glide wire is in the system, most important thing is that there is a possibility of dislodgement of the glide wire because it is unstable track, and so in order that it should not slip out and there should be through and through access through the cystoscope sheath, one can pass the biopsy forceps and hold the glide wire and bring it out through external urinary meatus. Because it is coming out through the external urinary meatus, there is a through and through access, so that possibility of dislodgement of the glide wire is 0. Also, Because of this, one can make the glide wire taut and straight, as a result of which it will help to make a straight track. So once the guide wire is in bladder, next step is creation of the track. In order to create the track which is straight, the guide wire should be kept, not guide wire, it is glide wire. The glide wire should be kept straight and taut. This is particularly important in case of obese patients because there is excessive subcutaneous fat, and so if it is not, glide wire is not straight and taut, there is a possibility of kinking, and this may result into, rather than straight track, abnormal track. On this straight and taut glide wire, initially the PCN facial dilators passed serially one after another by push and pull technique. After dilatation and creation of the track of about 10 to 12 French by facial dilators, one can pass the Alkem's cannula. During the insertion of Alkem's cannula, one has to take care that the glide wire is straight and taut, and most important that the tip of the inner straight sharp trocar is much away from the posterior wall of the bladder so as to prevent injury to the bladder wall. Now once the inner straight sharp trocar has entered and is observed under vision, then the outer hollow part of the Alkem's cannula is slided by corkscrew movement into the bladder, which is also observed under vision on the camera. Once the hollow outer cannula has entered, then the inner straight trocar of the Alkem's cannula is removed by push and pull technique. Through this outer hollow Alkem's cannula, again there will be efflux of irrigation fluid. So now in the bladder, now there is a glide wire and the hollow Alkem's cannula. Over the glide wire, through this hollow Alkem's cannula, one will pass the central guide rod, that is also under vision, and care to be taken that the bulbous tip of the central guide rod is much away from the posterior wall of the bladder so as to prevent injury to the posterior wall of the bladder. Once the central guide rod is in the bladder, then now there is a track dilatation. So first the 30 French Amplage dilator is passed again under vision by corkscrew movement into the bladder over central guide rod, such that the tip of the Amplage dilator is much away from the posterior wall of the bladder. Over this Amplage dilator of 30 French, the 30 French Amplage sheath is passed by corkscrew rotating movement under vision, that is everything is observed on the camera, into the bladder over Amplage dilator, such that again the tip of the Amplage sheath is much away from the posterior wall of the bladder. Now the track is created so as to achieve the waterproof environment. One will pass the stereodrip, and this stereodrip will prevent hypothermia, which is important so as to prevent the TOR syndrome. Once this particular track has been developed, now by push and pull technique, by holding central guide rod, the central guide rod and the Amplage dilator is removed. Now one will enter into the bladder with the help of nephroscope, irrigation fluid, light source, camera into the bladder. Once enters into the bladder, one will see the large calculus which is settled at the base of the bladder. Being large size, the stone has to be fragmented with various energy sources. Commonest energy sources which is used is pneumatic lithoblast. Once the stone is fragmented, then the stones which are of larger size can be removed with the help of PCNL stone holding forceps like biprong or triprong. In order to find these stones, always the irrigation flow should be reduced so that the stone fragments will settle at the base of the bladder. The other method of the removal of the stone fragments which are smaller in size and gravel is by suction or wash through the cystoscope sheath with the help of Toomey syringe or helix evacuator. So the stones which are of larger size, through the nephroscope, the PCCL probe, which is biprong or triprong, is passed. The irrigation flow should be slow so that the stone fragments will not fly away, and they are removed through the ampulla sheath with the help of PCCL biprong or triprong forceps. Whenever one has to remove the gravel or small fragments, the whatever is the ampulla sheath is seen that the flow is very low. They will settle at the base of the bladder with slow corkscrew rotating movement. The fragments will be pushed slowly by the ampulla sheath to one of the bladder wall. So now the gravel and small fragments are trapped between the lateral wall of the bladder and ampulla sheath. Through this ampulla sheath, now the nephroscope, which is in situ, that is in the ampulla sheath, special PCCL suction is passed so as to suck the small fragments and gravel. If the fragments are comparatively more and they are slightly larger but difficult to remove by biprong or triprong PCCL forceps, one can give the wash with the help of helix evacuator or Toomey syringe, which is attached to the outer end of the cystoscope sheath. In order to give this wash, here there should be some quantity of the irrigation fluid in the bladder. The nephroscope should be removed. The helix evacuator should be properly charged, that is, there should not be any air bubble, and or one can use the Toomey syringe and one use the forceful wash in such a way that the inner end of the cystoscope sheath is directed towards the ampulla sheath. So due to this vigorous wash, the stone fragments will fly from the base of the bladder towards the inner end of the ampulla sheath, and thus they will come out on the anterior abdominal wall. Once the procedure of the cystolithotripsy and evacuation is complete, one will do the check cystoscopy to confirm the stone-free state. Now here there is either one can put the suprapubic catheter, or one has got option that one will not insert the suprapubic catheter. If one is not going to insert suprapubic catheter, then the anterior rectus sheath should be closed properly with 2-0 or 3-0 Vicryl, and proper compression dressing has to be given in the suprapubic region. At the termination of procedure, perurethral catheter and or the suprapubic catheter is inserted. Now the advantages of PCCL are that in all group of patients, that is pediatric or elderly, due to PCCL, which is sizes of 1 cm, rather than bigger scar of formal open suprapubic cystolithotomy, much smaller size of 1 cm, there will be shorter hospital stay. The duration of indwelling perurethral catheter will be short. There is no instrumentation through urethra, thereby preventing injury to the urethra. Instrumentation, there is to and fro movement of the cystoscope for cystolithotripsy. Only cystoscopy is done, diagnostic cystoscopy with adequate lubrication, so there is no injury. In elderly patient with associated BPH, in addition to bladder stone, where maybe the bladder stone is secondary to BPH, then after completion of PCCL, one can safely go ahead with TURP in the same sitting, provided one inserts the suprapubic catheter through the tract, so that there is no extravasation through the hole in the bladder into periprostatic and perivesical tissue spaces. Complications, there can be injury to the bowel loops, Second, injury to the posterior wall of the bladder. If the injury to the posterior wall of the bladder is too deep, it may result into rectal injury. Third, accidentally coming out of the amplar sheath before completion of the procedure. Now, solution that the amplar sheath has come out, but the glide wire is in system. So what one can do? Direct the inner vesical end of the cystoscope sheath upwards towards the anterior bladder wall and confirm the site of entry of glide wire in the bladder through anterior abdominal wall. Once the site is confirmed, then under vision, that is on the camera, the glide wire, after holding it tight, the central guide rod is passed such that the tip is away from the posterior wall of the bladder. Once the entry of central guide rod in the bladder is confirmed, on that the selected amplar sheath is passed under vision such that the tip is away from the posterior wall of the bladder. And on this amplar dilator, now the selected amplar sheath is passed under vision such that the tip of the amplar sheath is away from the posterior wall of the bladder, and thus we are back into the bladder. Next complication is extravasation of irrigation fluid in periprostatic and perivesical spaces. This happens when there is a proper formal blood perforation or when TRP is combined after completion of PCCL without insertion of suprapubic catheter. Because when one performs the PCCL, it is like a perforation or hole in the extraperitoneal bladder wall. And if the suprapubic catheter is not in the bladder, in that case, the irrigation fluid which is been used, that is 1.5% glycine, used for TRP, will extravasate through this extraperitoneal perforation, that is hole of the PCCL tract, into periprostatic and perivesical spaces, and this extravasated irrigation fluid will absorb over a period and will result into the dilutional hyponatremia and delayed TR syndrome. Next complication, that is failure of procedure. Failure of procedure because of any cause, if happens, then what one can do? Solution is to perform formal open suprapubic cystolithotomy immediately. The same 1 cm incision is extended on the either side of amplar sheath to form phalansteal incision, which is proper phalansteal incision. This is carried out without removal of glide wire and amplar sheath. This is because amplar sheath and the glide wire at present are in the bladder, so that after opening the rectus sheath and retracting the recti, immediately, even if the bladder is sunk, even then, due to presence of amplar sheath and the glide wire, identification of the bladder becomes easy. Now, whatever is the bladder, once it is identified, it is picked up with the help of backcock forceps. 2 backcock forceps are applied on the either side of the glide wire or amplar sheath, and then the backcock forceps is used to retract the anterior wall of the bladder away from the posterior wall, and the incision is extended in downward direction so as to remove the large, big hard stone from the bladder without difficulty. After the removal of this, the rest of the steps of the suprapubic cystolithotomy will be similar to normal formal suprapubic cystolithotomy. Thank you very much.